Hey guys, Dr. Ash here. We're going to talk about postpartum. So this is really going to wrap up our maternity section, maternity health, that kind of stuff. So postpartum. So this is actually immediately after the birth through about 6 weeks. So the first 6 weeks after birth. And this is really where the reproductive system does a good job of returning to a non-pregnancy state. And so just like we did in intrapartum, we're going to do a couple of definitions first. And so the first one I want to talk about is involution. And involution just refers to the uterus going back to the same size. We do find that this takes a couple of weeks, and usually the fundus is back down into the pelvis, and you can't really feel it in the abdomen anymore after about 2 weeks postpartum. And just as a FYI, breastfeeding tends to increase the rate of this. And so, because breastfeeding releases the hormones that are responsible for contraction of the uterus, which makes it go back to where it belongs just a little bit faster. And then as this is happening, also the other thing that's happening is the endometrial layer is really starting to regenerate. Lochia is the actual vaginal discharge that happens after the birth of a baby. And so basically this is blood vessels, and just overall leftover debris from the uterus. Very common, very normal. It's going to start out a little heavier, and it should get a little bit lighter as we move on. It's going to start out in different stages. And so the first one is called rubra, and this just means bright red. This is like the first 1 to 3 days. Serosa, then it goes to more like a brown pinkish discharge, day 4 through 10. And then alba, which is a white discharge that happens day 11 to 14. And again, as you get further along postpartum, this discharge is going to eventually lighten to the point of resolution. The other thing that's going to happen is the vagina begins to shrink. However, it never really gets back to pre-pregnancy size. So even though it gets back to somewhat normal, it doesn't fully recover from delivery. A little bit about ovarian function and menstruation. So as soon as the pituitary gland returns to normal, because remember, pituitary gland is responsible for most of your hormones through your body, that's when ovarian function really kicks back in. Menstrual flow is going to happen about 1 to 2 months for non-breastfeeding women. For those that are breastfeeding, it may be 3 to 6 months, or it may never happen as long as they're breastfeeding. So just so you know, oftentimes breastfeeding will suppress menstruation. Now, the important thing to remember here is that women can still get pregnant because ovulation still happens. So regardless of menstruation status or not, especially if you're breastfeeding, there has to be some sort of form of birth control, or pregnancy is going to happen yet again. Breast changes. Our breasts tend to secrete colostrum for about 2 to 3 days, and then it's going to turn into what we have known as milk production, or letdown, or lactation, whatever you want to call it. And this happens because our prolactin levels increase. So progesterone and estrogen go away, and prolactin begins to secrete at a higher rate, and thus we have milk production. Now we have something called engorgement, which happens in about 4 days, whether we're breastfeeding or not. And this is really the kind of point where the milk has come in, but we get engorged because we need to feed. And so breastfeeding tends to cure breast engorgement. So for the ladies that are not breastfeeding, there are a couple of things that they can do. They need to avoid nipple stimulation, because the more stimulation, the more likely the body is to produce milk. Make sure that there is either a breast binder or a snug fitting bra, ice packs, and usually in about 24 to 36 hours, so about a day to a day and a half, this should resolve. So it doesn't last too long, thankfully. Changes to the urinary tract. So you got to figure everything is kind of gotten jumbled up and mixed up during this whole pregnancy and delivery fiasco. So urinary retention can occur because we lose elasticity, tone, and neural sensation to the bladder. However, bladder tone does return about 5 to 7 days after delivery. Diuresis will begin in the first 12 hours after delivery. Not only is this urine output, but it may be increased respirations, it may be perspiration. There's several different ways we know that we lose fluids, and it approximately is about 4 pounds that happens in the first 12 hours. And then at about 1 month postpartum, kidney function really returns back to normal or baseline. So it takes a full month for the kidneys to really recover. Changes to the GI tract, of course, hunger, because you no longer have the pressure of a baby, a uterus, and a placenta lying on your GI tract or your intestines. And so hunger is very, very common after delivery. There may be a level of constipation immediately after birth. And then, of course, good old hemorrhoids, which we determined has been an issue really since you got pregnant. So why would it change now? Couple of changes in vital signs that I want you to be aware of. And this is simply because we need to know the difference between what we expect and what potentially could be an infection or a situation. So it's interesting to note that immediately after birth, usually in the first 24 hours, there's usually a low grade fever. And this is really because labor and delivery is a dehydrating process, right? There's a lot of breathing, there's a lot of fluid loss. And so the body really is trying to compensate by having a higher temperature, right? Because the metabolism is sped up just a little bit to try to compensate for the dehydration. However, if there are higher temperatures than this, or they last into the 36, 48-hour mark, that's when we need to be concerned about infection. Pulse should drop into the 50s, believe it or not. There is a significant drop in pulse, but if it's greater than 100, we have to be aware that there is a high potential for hemorrhage. So we just need to be cautious that anything involving tachycardia could potentially indicate that there is a hemorrhage happening. Blood pressure should be normal. Again, if that happens to be low, we would be most concerned about hypovolemia. Respirations, rarely is there ever any issues with the respirations after delivery. However, if they should go up or complain of dyspnea, there's potential for embolism, uterine atony, or hemorrhage. And we're going to actually talk about uterine atony, so don't worry about that. We will come back. So what is the nurse's role in the postpartum period? It's really assess vital signs and the pain status. It's to assess the fundus. The fundus, or the top of the uterus, should be firm and midline, should not be boggy. Nobody likes a boggy fundus. Boggy or off to the side could indicate that the bladder is full. So we need to go empty the bladder or massage the fundus, or both. And if it's just boggy but midline, of course, we need to massage the fundus until it is firm, because firm equals contraction. We want to assess lochia flow, color, and odor. Again, the odor should not be completely offensive. It should smell like regular menstrual cycles. The flow, again, should lighten over time. We shouldn't be having a lot of peripad drainage, and we'll talk about hemorrhage here in just a minute. We want to make sure we encourage ambulation as well as voiding, and of course, assess bonding and emotional status. And again, well, I said this in the intrapartum video, but bonding is a process, okay? It doesn't happen because they immediately went to the chest after delivery. The baby went to the chest immediately after delivery. That does not determine bonding. Bonding is over time, so it takes more than one incident to get that where it needs to be. So a couple of complications that I want to talk about here. So we could have what we call a hematoma, and a hematoma is basically a collection or a pool of blood that's in the tissue of the vagina, or it could be vulvar. So it could be in the vagina or in the vulvar area. Usually the cause of it has to do with forceps delivery. So we didn't actually talk about that in the intrapartum, but this is taking, like, for lack of a better term, what looks like a set of salad tongs and pulling the baby out by the head. Well, the downside to that, obviously, is that we could cause some trauma to the vagina when that happens. And so we have to be on the lookout for hematomas. Findings, the woman often complains of a bulge or a pain in the vagina or the perineal area. There may be an inability to void because it's so large, it's actually blocking the urethra. Low H&H, low hemoglobin and hematocrit, tachycardia, hypotension. Nursing interventions would be ice pack, vital signs, looking for signs of shock, and assessing for infection, because those are going to be our two biggies here, right? We want to make sure that that hematoma is not bleeding internally, and we want to make sure that there's no infection from that hematoma. Uterine atony, as promised, this just means without tone. So this is a poorly contracted uterus that results in hemorrhage. Often what we find is a very soft, boggy uterus on palpation. Nursing intervention, the very first thing I'm going to do is I'm going to massage that uterus until it's firm. I do not want that mother hemorrhaging. So the first thing we're going to do is massage that uterus and then encourage emptying of the bladder, because oftentimes, again, that sensation is not there till about 5 to 7 days after, but a full bladder can 100% cause that uterus not to contract the way it should. Hemorrhage or shock. This is your number one complication of delivery. You see it listed 100 different ways, but this tends to be the highest tested concept, whether you're in nursing school or whether you're on the NCLEX, and it has to do with hemorrhage. So this is bleeding greater than 1,000 milliliters after delivery, so 1,000 mLs or more. It's at least a 10% drop in hemoglobin and hematocrit from the baseline. We all know that anemia happens in pregnancy anyways, but greater than 10% drop, we are concerned. And this can occur anytime during the postpartum phase. But again, one of the reasons why stage 4 of labor is 1 to 4 hours, because that first 4 hours after delivery, that's the highest risk. That is the high priority time to assess for hemorrhage. So a couple of different causes. Number one, uterine atony. We just talked about that. The uterus is not contracting. There could be lacerations or trauma to the cervix or the vagina. There may be a hematoma that's bleeding or leaking in the cervix, perineum, or on the labia. Or worst case scenario, there's some sort of retained part. So some of the placenta is left over inside of the uterus and it's causing the bleeding. Findings, what we're going to find on assessment. Number one, we have see the woman has soaked a perineal pad in about 15 minutes. Okay, that's very quick. They should not be going through more than 1 hour. So soak perineal pad within 15 minutes. Restlessness, tachycardia, hypotension. They are pale or ashen. They are weak. They are dyspneic. These are all signs of shock that we have to be aware of. So our nursing priorities for our hemorrhage patients. Number one, we're going to stay with the patient. Number two, we're going to call the OB. Number three, we're going to massage that fundus if it's uterine atony. In fact, if it's uterine atony, that's the first thing we're going to do. Elevate the legs to at least 30 degrees. Administer oxygen, 8 to 10 liters by face mask. Hopefully you've seen a pattern here. If you watch Intrapartum, you would have. Assess vital signs. Uterotonic medication, meaning we're trying to get that uterus to contract. So oxytocin or prostaglandins, such as methylgonervin. And the risk with those is actually hypertension. So we have to be careful on that end of it too. IV fluids, particularly lactated ringers, is the favorite of choice, and administer blood products if ordered. I think, yep, this is the last concept here is infection. So infection is a big one here. This is within 28 days of delivery. It is then determined a puerperal, P-U-E-R-P-A-L, puerperal infection, and that just means postpartum infection, just a fancy term for that. So again, within the first 28 days, again, that high fever starting at about 36 to 48 hours or beyond, if it takes a little bit longer to develop. Fever, chills, loss of appetite, pelvic pain, and malodorous discharge. Again, the lochia shouldn't smell completely off. It should have kind of a normal menstrual smell to it. Nursing interventions, of course, would be vital signs. Make sure they are comfortable. We want to isolate the newborn if the mother is highly contagious. High calorie, high protein diet for healing. We want to encourage at least 3 to 4 liters of fluid. When I say at least, that's minimum. Okay, we can totally go over that amount, but we don't want to go under that amount. And of course, encouraging bladder elimination, voiding, because we definitely don't want a urinary tract infection on top of everything else. And so those are your major things to do with postpartum. I hope you learned something. If you do, make sure you like, comment, and or share, and I will see you guys in the next video.